都在这边。
开始了，开始。
For sure. Are we on? Are we all ready?
We're on. Ready to go get started? Good morning, everybody. Welcome to the rehabilitation unit here at Loyola. This is our 9 a.m. intake meeting. This meeting actually has a number of functions, but we use it as kind of a morning report, a daily intake meeting, a meeting where we talk about any issues or problems on the unit. We also decide who's being admitted to the inpatient rehabilitation unit, who's being discharged. So you'll hear a lot of this is a working meeting for us. We're just going to go ahead and have a regular meeting, and I know our observers here will enjoy the process. So go ahead.
Discharges are confirmed. Let me just say the first one is on North. Yours is okay?
It's okay to go.
My two are okay to go. I think that Donna was talking about dates home health instead initially for the one. Yeah, if that's okay. Yeah, she doesn't switch.
Okay. So we'll have 3 beds.
The first patient is medical record 1949301.
That was Igor? Igor.
Okay.
Okay. So I actually did not see him yesterday, so I don't know the status of him today. But he is originally got hit by a car and the car versus pedestrian. Had a lot of complications. They tried to salvage the limb. Last Monday he went for the knee amputation. History of severe depression that would interfere with therapy. Like I said, I did not see him yesterday. In my last note, I recommended for him to be assessed by psychiatry and to be started on antidepressant. He was otherwise medically stable, and the only thing that was there was wound vac on the right residual limb, and that was still gonna follow up with the wound care. That was the only 2 issues was the wound care, ongoing wound care, and depression, major depression.
You know psychiatry saw?
I believe psychiatry saw him. I think they said that his depression was in sync with what happened to him.
Oh, right.
So in other words, he had a situational depression. Right. He did have the through-the-knee amp. He was in too much pain yesterday to participate. Prior to that, he was bed mobility max of 2 and pain for the max of 2. This morning, his WBCs had gone, he's been hovering in upper 10. He'd gone from 13 to 17.9, about 18 this morning, which could have been post-op, but he also is running 100.2 fever. So I called the social worker yesterday just to check on that. Hemoglobin and stuff are holding in the low 8s, but they had him down in the 7s before and didn't get his blood. The question on him, too, is his wife has been kind of iffy with the social worker, and she wasn't sure where she wanted him to go, here or Marion Joy. Marion Joy knows that he's a public aid pending, wanted all the paperwork finished before they made a decision. I think if we have the bed first, that they'll talk to Rice and let him come here. But she brought her up for a tour, and the woman just kind of said, oh, never mind, it just left. She's got 5 kids or 6 kids or something on top of what's going on with him. So it would be a pair that we would be working with. And I did ask her to check on those labs. I'm not real comfortable with the fever and WBCs.
You know, the wife did come up and get a tour.
And she left.
No, I gave it to her.
Oh, did you?
Yeah, I gave
what
her
the
like
social
a
worker said was
15-minute tour on Monday.
Okay.
Yeah, she was
Maybe
there
she
for
came
quite a
back.
while.
That was before. That was last week. So she must have come back on Monday. Okay.
But she still is, and the other thing is he had a revision on Monday. So I don't think he's got the wound back.
No, we don't know what the wound care is now, but I assume there's going to be some kind of dressing.
Yeah, it's dry. I mean, it's...
So we're going to check on the source of his fever and white blood counts, and then he wasn't really participating very much yesterday, didn't sound like.
Pretty slow to mention.
Yeah, if you want to hold the day just for that, just to free him from something.
And the next patient, 0342077.
So this is a 66-year-old woman who fell actually from a golf cart, fracturing her pelvis. So she has been somewhat slow to mobilize. Otherwise, is in pretty good health. Married, lives with her spouse, and really pretty much pain issues as far as her participation in therapy. We said yesterday when I saw her was that we would, she would be home versus acute depending on her ability to get up and around. So I think if she's medically stable, I think if she's still not able to get up and around, I'd go ahead and take her.
She did better in the afternoon.
Yeah.
She was sit to stand min. She had been maxed. She went 20 feet rolling walker, contact guard, limited by nausea, 45 feet rolling walker, contact guard. But doesn't feel like she could go home. Vital signs are stable, exercise, and Blue Cross gave her some medicine. So figure.
Go figure. Gave us a week. No, she really doesn't need medicine. She's very medically stable. Okay, so let's take her. She's a keeper.
It does look like she doesn't take quite as much pain medicine.
Right.
She might
kind
need
of
it.
Medical 087-3369. I don't think this patient's actually been seen yet, but you've had it before.
Oh, you've had it before, okay then.
Has been here before. 72-year-old female with surgery for aortobifemoral bypass. Came in with claudication. Apparently underwent some kind of revascularization. Bilateral, kind of a redo bilateral bifemoral bypass. Widowed, lives alone, house with one exterior step, complex the basement. But prior to admission, is independent and everything. So do we know how she's doing now?
She's doing really well. Supine to sit supervision, sit to stand, stand ISIS, 125 feet of contact guard with 2 rest breaks. Lower extremity dressing dependent, toileting, contact guard. The therapists are still saying inpatient because she lives alone. I believe she's got 3 more stairs.
Yeah, one exterior step and complex the basement.
Eric said I should mention she has problems with the bathroom, and she lives alone.
That's actually good.
Kathy, what do we have as far as our census? I mean, like 65%.
We're at 58. She's pretty high level. She'd probably be short.
Yeah, that's what we talked about.
Our discharges for today, are they red or green?
They're, let's see, 1 red, 1 green, 2 green. 2 green, 1 red.
So that's 66%, right? Creeping up there.
Then tomorrow it'll go down. Now, does she want to come, by the way? I mean, because I think we had this other issue before with this one that we did today, that she didn't really want to
No,
come.
she verbalized that she thought she needed more.
Okay.
I think because maybe she's been here before.
Okay.
Yeah, I remember.
And we have a 27-year-old male with a history, with a background in football and powerlifting, some history of low back pain, status post L4 to S1 decompression with fusion on the 12th of August without any significant involvement of pain symptoms, unable to fully participate in therapy due to pain, lives with parents in the late 50s in their house, on long-standing history of opiate painkillers, does not think he's going to be able to participate in 3 hours of therapy a day. Pain has followed and signed off with the lack of increasing his fentanyl patch, admits to being depressed as well. Exams limited to pain, but very strong. Even our upper extremity strength check gives him low back pain. So he does not want to participate in 3-hour therapy a day. He admits to being depressed, that needs to be addressed, and he's a good candidate for home with home health if he's unable to. He just got approved for Social Security benefits at the age of 27. He just got his first check.
The thing is, he's not assisted too, so
It's
they're
due to
looking
pain,
for
though.
a
It's not
versus.
money.
But if he's a modest times 2, they're saying he can't go home. So maybe we need to say home versus subacute or something in there. Because I got a call yesterday on that.
Well,
how can he go home if he's a modest too? So.
You know, this guy, we were talking about him earlier, he would be perfect for an inpatient chronic pain management program. You know, now there are very few and far between of those. I don't know if RIC still runs one, but, you know, I think a referral to an inpatient chronic pain management program for opiate weaning and, you know, all the kind of psychosocial stuff that he needs,
I don't think they got the inpatient.
might be an option. You know, I know that Mary Joy doesn't run an inpatient chronic pain program anymore, but there are a few of those still around. I think this guy would be, you know, pretty much a perfect candidate for that. But I think if you bring him into our unit, what you're going to find is he's going to become more and more dependent because we really don't have the psychosocial milieu, you know, the biopsychosocial model that really would be able to, you know, fully address all of his issues. So I think our unit is not an appropriate place for him. You know, probably if you decide, if you want to say what level of care does he fit into best in our system, it sounds like it's a, you know, inpatient chronic pain management type of.
Will they take someone who's? I know that he probably isn't, but he's coming across as a therapist as a modest too. Will they take someone? Just because they're asking us, we just need to know how to answer. Because they were very concerned about the.
Yeah, I mean, I think the inpatient chronic pain programs that I'm familiar with are, you know, are ones that, now, they may say he's too acute from the surgery, you know, that they don't want to take him that immediately. You know, he had surgery, week after the 12th, a week ago or so. You know, they may want him to recover from that, in which case, then, I still don't think this is the appropriate place for him.
We knew that. It's just that they called us and like, but he's a minor too, so he can't go home.
Is it the same guy who Riverside rejected?
Yes.
Yes.
He's been rejected at least twice now, and acute and a subacute, for the same reason.
Right, I mean, acute
They just
inpatient
don't
rehab
have
is not a
to
good
say,
place for
"I
this
need
guy.
one."
He's just going to become, you know, more dependent. He really needs psychological support of a chronic pain management program.
Okay.
So we have down on that.
I think so.
This guy hasn't been seen yet either.
Yes.
Oh, yes, I see it. Okay. You have another?
Yeah, I just need to finish. So this is the 66-year-old guy with Hep C, cirrhosis, and mass status post-liver lobectomy. 20 days ago, went home, came back with hypernatremia of 114, 115, and obviously ascites and large scrotal edema. Since then, they've been managing his hypernatremia and hyperkalemia. That's been trending worse than normal, still hypernatremic at 1.7 now, and trending up. Hyperkalemia has also been addressed. Renal has seen him, thought it was due to hypervolemic status. Pain issues in therapy. If he does not wear scrotal support, his therapy is limited to pain. He wants to go, and his family wants him to go to the subacute center by, I forget where he lives, but by the place where he lives. Yes. Baseline prior to surgery, he would exercise an hour a day, bicycling on a stationary bike, lifting weights and walking. After the surgery, limited to household ambulation. Main issues, owing he lives with his wife, who works in the first half of the day and back home by 2. Main issues with him is low endurance and pain with ambulation if he doesn't wear the scrotal support. He's not listed for transplant anywhere that I've seen in the notes. So with him, it's pretty much endurance training, making sure he gets back to his normal lab values. They want to send him out today, and I think he's a subacute candidate. Yeah.
Yeah, I would agree on that. Subacute rehab is the best place for him. Now, did you want to talk about the GBM patient?
GBM patient, absolutely.
Yeah.
We can print him.
So we have a 69-year-old male person with about a year history of GBM resected in June of 2007, status post-radiation and ongoing chemo, currently on avastatin. Dr. Barton is his Loyola oncologist. His next treatment, chemo treatment, is scheduled for this coming Friday, but it was arranged with the oncologist that it can be indefinitely delayed. He gets his chemo every other Friday. Lives at home with his wife, and his son just moved back from Texas and is going to live with them. There is a couple more kids in the area who are all adults and all participate in his care. Baseline, he can actually walk for a few blocks, as the patient's son described it. He can walk indefinitely, actually, but it's limited to his intermittent confusion state. Happens pretty much every day for several minutes when he forgets where he's going. Otherwise, confusion is limited to just forgetting his intentions. He still recognizes the family and is pretty safe at home. Walks with cane, one single point cane. Was admitted on the 17th with a new onset of left hemiplegia and left-sided neglect. He also has a new onset of partial complex seizures with he was seen by a neurologist this month, so the onset is within 30 days. Ever since the admission, his mental status has improved since Sunday, but per son still below his baseline. His functional level has also improved. He now somewhat recognizes distal upper and lower extremity when touched, which was not the fact on admission, and also his strength is improving both in the upper and lower extremity. It was 3 distally both in upper and lower extremity, and about 2 approximately, but he still neglects the proximal part of his extremities. He was alert and oriented times 2, recognized the family, knew the date, and knew where he was. Short-term memory is severely affected, but it's a baseline per patient, per patient's son, ever since the surgery. So given the prognosis, the right side, by the way, is 4+ throughout. He was cooperative with the exam, followed commands with exception of the left side when he needed both verbal cues and tactile cues, and there was probably 25% of following the commands on the left side. He did acknowledge me being on his left side, even though on admission it said that he would completely neglect the left side. The neurology people made him draw the clog, and he was able to draw complete clog without any problems there. So given the prognosis and the patient's family desire to take him back home with home health, which it looks like it's been arranged already, but they want to switch the home health agency. I think it would be appropriate to, if the patient family agrees to take him here for a short term with very limited goals, probably transfers, and send him back to home with home health and following up with chemo every other Friday, as it was scheduled before. We're his oncologist. It's okay to delay his chemo for the time being while he's here.
This is a fellow that you really don't want to keep in rehab too long. I mean, basically, he doesn't have a very good prognosis. But if there's some very specific goals, be able to transfer, get the family trained, get him home. He's got a new onset of this hemiplegia, hemiparesis. So, I think that's an appropriate use of us for a short stay.
Did they do any surgery or anything?
They did an MRI. There is no evidence of acute ischemic or any kind of CVA. They attributed to his GBM. No.
But yeah, I thought maybe they were treating with steroids or something like that, but apparently it's just getting better, on its own, so.
He's on phone.
What's his MR number?
188-96.
What is it? Sorry.
188-9649.
Yeah, because mom was switching.
And the family understands his chemo will not be given while he's...
Yeah, the son, I mean, I spoke to the son, he's fully aware of the situation. The wife is the power of attorney. 22nd, but it can be, it will be delayed.
I would think you have about a week Wednesday. Okay, so don't go with that. Any nursing issues? Good. Any other issues?
I just need to confirm, Mr. Simon, IV antibiotics going from September 4th.
It's written in my progress. It should be.
That's what we're doing.
Well, very good. Do you, our visitors have any questions? Well, that's our process. So what you saw today was our intake meeting for the acute inpatient rehabilitation unit. It is a subset of the hospital patient population that needs inpatient rehabilitation, and it's kind of the way that we go about the process. Thank you for your attention.
We can
Enjoy your visit.
also talk a little bit more after the physicians are done. We can tell you a little bit more about rehab, and then we can explain a little bit more.
Thank you.
Char, can you flex this is a little bit of a sampling. This is what we do at the 9 o'clock. We screen and make sure that all the patient's needs are assessed, especially discharge. I know discharge planning is your priority. You might have met Barb already.
见过吧？我刚才是最好你的问题是吗？
没有，他们大概就是 everyday 还是
Do you do this every day?
Yes.
Every day 9 o'clock.
In fact, we wanted to show you that before they come onto the floor, we give them a tour so that the families are aware of what to expect. So there's more questions asked before they come, and there's hardly any surprises, so that they kind of get all the hard questions. And that's what Kathy can maybe explain a little bit more, because they come up and give a kind of like a tour, a question answering, a welcome and admission type of breakdown for the families and the patients before they even come.
他就是先给
So we can show you. This is for you guys to keep.
家庭里面的人有资料，所以病人进来的时候就不会很
This is what we do here when we get admitted to the floor. We have several disciplines here between therapy, nursing, physicians, social work. We try to keep everybody together so that we all know what's going on and that the patient. This is a little souvenir from us. If you guys want to keep, please have every one of you guys keep one. You're also welcome to keep these as well, because we always forget when we are leaving that we want to make sure you guys all have a souvenir from rehab. So basically, in a summary, if you look at each page, we won't go into much detail because I know you guys' time is limited. We put a welcoming. There is a letter from our director, Paul Gorski, myself.
他的主管呢在这边，跟他就是欢迎，这第一个信就是欢迎家人。
And pretty much it brings all the disciplines of rehab together so that the patient, there's less, I mean, we still have some communication gaps, but this helps decrease a lot.
这个帮忙很多了，虽然可能都有。
And then every Monday and Thursday, we have what's called new patient orientation, and either myself or Yolanda lead a group with the new patients and their families. And this book, we actually go through it, and we tell them all the routines on rehab, what to expect, how we're going to help them get home, because rehab is to us, so different than being in the regular hospital.
星期一跟星期四，他都会见那新的病人，告诉他们这边的情形是怎么样，因为很不同的。其实病人都留了很久吗？有没有问他？
What we do before they even get admitted is whether or not we can actually, I know discharge planning is your goal, is whether or not we can meet those goals, they qualify for any type of insurance, and at the same time, as they progress, we can see how they're all progressing in one spot.
所以他们的目的就是他们出去嘛，就是也看他们的保险背负多少钱。
So maybe you guys can correlate this somehow to where you guys are, and put it all together so that everybody's. I don't know what your process is, and
他不知道你们是怎么样，就是用这个做的资料来做你们应该做的。
I think if I could make a summary of what we try to do with the unit here from a patient family education perspective is when a patient gets sick, they come to the hospital and they receive treatment. They lay in bed. The physician, the nurse, takes care of them, and the patient is somewhat of a passive participant to their care.
当病人进来的时候，他躺在床上，只有医生啊、护士啊都照顾他，所以都是给人家动的，好像木偶一样，所以。
And when I say passive does not mean that they're not informed or educated on what's going to happen to them.
他躺在床上，不是说他不知道自己做什么，就是。
Patient is in bed. I'll pretend I'm the surgeon. I will perform surgery on you, and you get better.
他譬如说他是医生开刀的话，他开刀之后你就好一点。
On this unit, the focus changes, where the patient isn't the passive participant, they are the active participant.
这边就不同了，病人要跟他们一块做的，好像刚才讲开刀，你就躺着给他割，在这边你要动，对不对？
When they get to this unit, the surgery is over. The main parts of their treatment were addressed. Now on this unit is where at least the 3 hours of therapy begins.
他开完刀已经完了，他已经医好那部分了，但是呢，主要其他的问题就开始了，他们就要教他身体其他的问题了。
So the patient is not encouraged to lay in bed. They are encouraged to get up, exercise, perform their own self-care, build up their endurance to get back to what they were before they came into the hospital.
在这边就不同了，他不是躺着了，他又时常动啊，他动到他可以回去出院的时候跟他以前一样。
And that's why we try to convey that message to our potential patients as much as possible before they come to this unit, so there's no surprises.
所以他尽量跟那些快要来的病人讲，所以来到呢，他就不会觉得不同啊，近期为什么会这样子。
And then from a discharge perspective, with the help of Barb and her colleague, after their injury or illness, they come here. About 70 to 80% of our patients make it home after they leave this unit.
因为包的帮忙，他的同工的帮忙，所有病人他病了之后上来之后，70% 可以出去。你有没有问其他？
这边大部分的手术就是 cardiac 还是任何手术术后
Any surgery after they need rehab, they come here. What kind of surgery they had, then they come.
You know what, if I can address the rules that we have here is for a rehabilitation unit, 60% of our patients have to fit into categories that the government has said, these kind of patients have proven they need rehab. Stroke patients, brain injury, spinal cord, Parkinson's, all those neuromuscular, they're all approved to come to rehab pretty much.
等一下啊，他也是政府要控制了。你刚才问什么病人进来嘛？中风啊，腰伤啊，还有什么另外一个脑伤啊？政府说这些病人都可以来这边康复。
这里也是算综合的，就是 combine in every maybe several kinds of disease. Yeah.
But so that other 40% is the kind that we will take any kind of surgery, transplants, heart surgeries, all that kind of stuff. Any patient, the big thing is that through whatever has happened to them, they have gotten weaker and they can't take care of themselves. So there's two things that they, really have to do in order to come here. They need a doctor to watch over them yet. They're not totally out of the woods, and that they have physical impairment, that they can't walk, they can't dress, they can't.
所以其实你的问题就是，其实所有的人都可以来，但是分它两大类的，就是政府说那些一定可以来，那其他的开个什么手术，医生需要 ，doctor 要医生，你还是看医生，医生可以教你来。
About 40% approximate of our patients that we get on this unit have a neurological condition. That could be a stroke, or it can be a neurological surgery. May it be, central nervous type system type surgery.
他说这边大概是这个 percent 就是神经科转过来。
Some orthopedic surgical conditions would qualify as well.
骨头开刀可以过来。
If you broke your wrist,
手断了。
You wouldn't make it on the unit.
你不可以来这边。
That's not bad enough.
不够伤，不够重。
But if you broke this wrist, this hip, and this hip, yes, you can come.
很多地方伤的就可以来，要问他熬多久。
The average how many days maybe the patient's length of stay?
Average is 12 days.
12天，通常一般来讲在这边都12天。
Do you have anything similar to this?
你们有没有这个部门呢？
We have
another hospital, but not in our hospital.
Okay. So if you take care of a patient who has a stroke, is it more the family will take care of them when they go home, or they will go somewhere else?
中风之后怎么办呢？他什么
？It depends patient's family choice. Maybe family want to send him to a nursing home.
I think most of the patients go home.
Do they?
Some of them go to nursing home if they have no family to take care, or another caregiver to take care at home.
I may be wrong on this culturally, but I think you have much more family support than we do here, I think, where the family is expected to help with their care. Are they or no?
是不是I think they not. 哎呀，你家人帮忙很多，社会里面期待是家人去帮忙那个病人康复，是不是在台湾？其实中国人呢
？Yes, the patient may be want to go home, so sometimes not the family take care. Sometimes they hire somebody to take care at home. Yes.
But we have the physical therapy department and occupation department. So after the patient go home, the family will assist the patient to maybe day. They will send the patient to the physical therapy department. And maybe 2 hours or 1 hour they will go home.
Like outpatient therapy.
But but not in depression, this unit, not like, it's different.
We can take a quick tour too afterwards, where we can show you our gym and everything if
我
you
们一
guys
会儿
are
出去
curious.
看看他的看看。
One question. There was a patient at home.
你去门诊的
Physical
话，
therapist
产生很多伤的
will
帮你们
go home to visit. Like a stroke, they have difficulty to go back hospital to exercise.
There is home care, yes. There's
Yes.
home physical therapy, occupational therapy. Speech therapy is very difficult to find in the home. There aren't that many speech therapists that go to the home. So that's one problem with home therapy. So if someone needs all three, speech, physical, occupational, we try to send them to an outpatient center after their stay here.
所以他们是把他转到那个外面门诊。如果他之后 stroke 给他出院，还要继续复健，就是在外面的。
Outpatient. In our hospital.
We have many outpatient centers. We have some a few blocks away. We have some in different communities. There are many outpatients. Yes.
And the physical therapist visitor the patient is including the insurance, like maybe kids.
Physical therapy is covered by their insurance. Yes.
通常都会包括的。
Outpatient and inpatient.
Include the dietitian, nutrition,
Dietitian, usually they have to have a diagnosis for their dietitian.
通常有
So
病才去看。
diabetes, some kind of bowel
糖尿
problem.
病啊，肠病、大肠病。
But we have a dietitian that sees everyone here while they're in.
这边有营养师见每一个病人。这边有。Do you have a question? The team make up of the meeting before. The team is make up of who?
It's,
Our 9 o'clock meeting?
Yes.
Yes.
It is our physical medicine physicians,
就是他们康复的医生，
our internist physician,
内科医生，
nursing leadership,
护士长
case manager,
，case manager。
physical therapy is usually
PT.
represented. Anybody else?
And then intake.
Oh, of course. Our intake, those are the two individuals right here.
What's the intake? Nursing?
Good question. Intake, we have, let's say, 400 adult beds here. We have a 24-bed unit. So 400 beds to 24, a lot of those referrals go to the intake people, and they start reviewing the case to determine who's appropriate, who's not appropriate.
他那个 intake 的意思就是看看谁可以在这边住。
And then there's this.
他们是护士 ，intake 也是护士，但是他们是看看哪一个病人可以在这边住。And what happened? Those
Arrange the
could not-
priority of the patient. Priority.
Good. That is what we have to address every day. For example, the one case today was the individual that had a lot of pain control issues.
刚才讲了一个很痛的人。
We really can't address that as well as it should here. We don't have the environment for something like that. So.
And a lot of times if we have to choose, where we talked about the 60% of our patients have to be fit in a certain diagnosis. Sometimes if we have a stroke patient and a patient who had heart surgery that maybe had complications, and they have the same deficit, they both are the same as far as their weakness, we would probably take the stroke patient because Medicare allows strokes. So the people who fit into the 60% sometimes get priority over people.
他刚才就是讲了，刚才是有些政府说哪一个病人可以在哪里住的这样，就是同样需要的，这可能都先拿上面那些病人。
60% 是怎么样？
就是政府 Medicare 是一个保险，政府的保险，说这些病人可以来做看护，他们就先给那些病人。他60%大部分，60%的病人是那些病人。
I have a question for you.
你们询问题。
Taiwan has a national health care system?
政府有。
Yes.
So there's certain rules, regulations that you would have to abide by to keep a hospital open. And what Kathy was mentioning about the certain diagnosis is the rules that we have to abide by.
他说你们也有规定，政府也有规定吧？有没有规定？像他们拿钱有没有规定？怎么样做才可以拿钱？
有健保局或那些吧。
Just some disease, not all.
Correct. Actually,
这边也是啊，有中风啊、老啊、背啊。
The green represents the ones that are compliant with the rules.
绿是就是政府的规定条件。
The red are the ones that are not.
所以红是就是另外一个40%。
There needs to be a certain percentage of green versus red.
所以他们有分开，里面拿多少人进来，另外红是有多少人进来。
The green and red is a homemade tool that I think Kathy and Intake came up with to help us watch that all the time.
钱啊，
可以家属跟病人如果不想出院，他们就可以不用投啊。那住院结束就会延长。
Insurance is not limit the discharge, so so serious, so strict. You know, just sometimes shock take a long time, maybe 1 month. If the patient doesn't refuse to go.
They stay a month?
在留在医院，我想你们，他留在医院1个月。
If they don't want to leave, they don't have to?
Yeah, they can.
Oh.
It's difficult.
But do they get PTOT during the time stay?
Insurance doesn't
Okay.
limit, so strict.
Wow.
Yeah. So maybe change in the future.
Yeah, that's what happened, how we progressed.
Yeah.
Strokes used to stay, oh my gosh, before they would even go to rehab, they would stay in the regular hospital for 3 weeks. Now we get stroke patients maybe 5 days, 4 days after they've had their stroke, they come to us.
Oh. If they go home here, they go to another hospital. This improves the length of day. Yeah. If go to another hospital from here, if they discharge from here, and then go to another hospital.
They probably wouldn't go to another hospital.
Yeah, no.
They come.
They would go to a nursing home if they can't go home.
Yeah.
Because in our country, they discharge from this hospital, and they go to another.
They go to for the same disease?
The same. The hospital shopping.
Oh.
So maybe they stay 3 months in another.
Wow.
Totally.
I have another question for you, and I'm very much interested in national health care systems. And I've heard good things about your national health care system. What's your impression of it?
他们觉得不错啊，你们的 healthcare system。
你觉得？
你觉得？他们觉得好。
It's good for the people, but not good for the
government.
不是那个hospital's member, just staff. Yeah.
Okay.
Because they many disease and include many disease. You know, they don't pay much money.
Like here.
Yeah. The patient doesn't need to pay much money.
Yeah.
Just pay little money. Include many disease. About 90 people has health insurance, so almost they go to hospital, just pay a little.
Okay.
And but they pay the hospital just less money.
So what if you want to have a knee replacement? You have arthritis, and you go to the doctor and say, my knees hurt, I want to have a new knee put in. Can you do that?
Yeah.
No problem? You don't have to, okay.
Total knee replacement.
You don't have to wait a long time?
No.
Okay.
Today and tomorrow, okay, operation.
And that's what I've heard about your system, where if you wanted a knee replacement or something like that, it could be done right away.
Yeah.
Wow.
Wow.
And the implant doesn't need to pay. But if you need a more better implant, you just pay money. If you pay the insurance implant, you don't need to pay money. Very quickly. The people in our country can't wait more because more time, because they can go another hospital.
Oh, they go okay.
And they will complain. Yeah.
Are there any private hospitals where you just pay if you want private care instead of the government care?
私家医院有没有私家医院？
We have about six hospital in our system. 他问的是我们
私家医院。
私人医院 OK。
私人医院。
私人医院
有没有私人医院？
有，我们就是私人医院
private.
We have many private. Yeah.
Okay. Any other questions for us?
I think the length of days, 20 days, is so short. So short.
12天。
It's imagine in our country. So I think how 有没有什么阻碍？就是说 you have any problem when patient has some against the discharge?
We do.
How can you do so short time?
Some patients really want to stay longer.
Yeah.
Some families want them to stay longer. But we can usually, if they have goals, if they're making progress, then we all get together as a group and we see if we can keep them longer. But sometimes we just have to be honest with them and say, you're ready. You're ready to go.
有些病人想留下来住久一点，但是他们达到他们
And
想要的，他
rehab,
不
this
可以啊
type of
他说你要走。
nursing or this type of a unit is considered keeping patients long. I mean, compared to the regular hospital,
前面已经住很久
it's
了
the length of stay is probably 3-4 days.
Yeah.
That's for an average surgery or whatever. This unit here, this is considered very long, how long we keep ours.
I think that from a personal perspective, more mobilization, the sooner the patient gets in the door, the better. Their length of stay will decrease, their outcome will improve. An example is back in 1992, when I started here, our length of stay for our joint replacement patients was 5 to 7 days for
以前是5到7
a no complication joint replacement.
不复杂的。
Now it's 2 to 3.
现在越减越小了，2到3天4盖。
The outcome
4盖，他的病
is
人他讲的病人
just as good, if not better, and the patient experience is just as satisfied, if not better. And why
是
that's
说病人就要动，不可以坐的，病人出来要动。
and why that has occurred is better use of anesthesia, nerve blocks versus general.
喜欢是
Therapy, seeing the patient sooner. They'll change in some of the surgical techniques. put all that together, and the outcome again improves, the length of stay plummets, but the patient is happier because our patients want to leave the hospital and go home and be with their families.
他就是在动，这边是在动的，所以不会留在这边很短的时间，他回家也快乐一点。
Who helped the patients early ambulation, early work?
Oh,
Usually the therapist.
Therapist.
They start therapy on day 1 or day 0.
Day 0
他看完手术的以后，他动了。
is the day when the therapist sees the patient.
Oh, this is post-operation.
Operative day.
Operative day.
The pre-operation.
No,
Post-operation.
If someone's having a joint replacement today, now, they will see a therapist this
当然
afternoon.
了，
Right after surgery.
After surgery.
Yep.
Post that day 0.
What kind of surgery? I should have a question.
Joint replacement.
哦，就是 joint
TKI.
How about you guys?
Yeah,
How soon do they get up?
We also
Yeah,
mentioned you
是
before
在呀换那个马
for
上有什么你
7
们呢
days.？
那个好几天了。
他不可以。Oh, the day after.
The day after?
现在呢？现在这样的。
Like the nurse
护士
helps
帮
them
他
or
们
is
动
there?
吗？
现在是今
护
天
士帮他们
做完手
下
术
床吗？
动。
哦，动啊，是动。
护士吗？
没那么快。
OK，看这个是不是 PD 还是？
好几天吧，
而且没有附件是去看
2-3天。那个偷偷你的话只可以下床，那个
对，
好几床的。
隔天有办法吗？
没有呀。
You go to the nursing home. The insurance cover the nursing home.
For a longer time period. But in a nursing home, it's at least 20 days, and most patients have insurance that approve 100 days in a nursing home. So it's a much longer.
Oh, another insurance.
Same insurance, just a different place.
Oh, different
Different
place.
care. This
Oh,
is considered hospital
Yes.
care, and a nursing home is different, so the insurance treats them differently.
The insurance covers the
Covers
nursing
more
home.
in the nursing home.
And how long they can stay there?
100 days.
100天。
100 days. Oh. And I want to know about the discharge, because less of days, 12. Every disease has a criteria, fitness criteria to go
钱
home
一定比较便宜。
in
医院
this
不
world.
同啊，你的用具什么样？
You know what? We have what's called team conference, and like if one of our patients comes in today to rehab, say we'll say a stroke patient, either tomorrow or Friday,
人的照顾也不
their therapist, their doctor, their nurse, their discharge planner, they all meet and have a meeting and say, how is this patient doing? What do they need to be able to do in order to go home? And how long should they stay? So even if they're going to stay till 30 days from now, we make that decision by Friday. So even if it's a stroke patient, we say sometimes stay a long time. We'll say this patient can't do hardly anything for themselves. They need maximum assistance to get out of bed, to dress, to eat. They're looking at, we need to keep that patient at least 3 weeks here before we're going to see improvement. And then next week, the whole team again talks about the patient every week and decide if that discharge date is
这
still
边最
good.
重要是有目的。病人进来之后，所有的人都要看看，评估他可以什么时候出院。虽然说第一次看他是3个礼拜，但是在下个礼拜再看的时候，要是他好一点啊，也可以改的那个时间。它就是最重要这个目的。每个病人他们所有的护理人员都要写出他们的目的，要什么时候可以出院。
我问一下，他每天早上不是有这样的刚刚那样的 meeting 嘛，对不对？然后他刚刚有每周这样的，这是另外的，是不是
？Okay. The meeting you said this morning 9 o'clock is every day, right? But you have mentioned once a week meeting? Are they different meetings?
Well,
Yeah.
4 days a week, we have meetings on all the patients. So at least once a week, every patient gets a team conference.
Because this meeting talks about patients that aren't here yet.
Intake.
This other meeting we're talking about, it talks about the
Here.
patients that
Okay.
are here.
所以今天早上那个就是选那些人进来，谁可以谁可以在这边住，然之后4天一个啊，1个礼拜一次那个讨论这些病人。
So that usually happens like towards the end of the day. We even have meetings in case the families have concerns, so that by the time if they have any problems, we invite them for a family.
他说病人有问题也请他进来一同的商量，解释给他们听。
Team conference 是至少每周一次这样。
讨论病人每周一次。
Like the people enjoy the participation like this morning.
It could be, or it could be a little bit more,
Okay.
Condensed to see who can, address certain, issues. If there was a nursing issue, if there's a therapy issue, a family member could come and we can highlight those and bring special attention to it. Some of them have questions about their care and they look at, what we have here. We can answer those questions right in the room.
The criteria patient can discharge is the same with like a neurological ward or another ward, the same. The criteria is the same.
Yeah.
Okay.
A patient has to keep making progress to stay in the unit.
So the same criteria to discharge.
Not to get too complicated, but we use a number system. Again, all the rehab hospitals everywhere use this same system. And it's number 1 through 7. And you get a score on 17 different areas. Bathing, dressing, walking, feeding. 1 is you have to do everything for that patient. 7 is they do it totally themselves. So when we're at this team conference, we use the numbers. We say dressing is a 4, eating is a 5, meaning that's the amount of assistance. When patients are at 5s and 6s, if they can get that high, they're ready to go home, no matter what the diagnosis.
I think we're limited for time, so we're going to take you for a quick tour because I know some of you saw the gym.
我们看看他那个运动那边，我们出去了，因为时间是问题。
Just enjoy your... So we have that in mind when they need their therapy. It makes a difference. It makes us, because we're nurses, we don't want to break our back. It's easier to get in.
跟厕所不一样。马桶也比较
So in the wall, it's really a wall taller than what we normally do. We do have equipment that's adaptable to the toilet. But here the Americans were bigger. So you could probably adapt it to the size of the individuals here. But the room is larger. Families are encouraged to stay in the room. So we have a bed that we can roll in. They can stay. And then I'll show you really quickly the gym because I know they want to take you away.
有没有病人可以照一下？好。
这个可以照什么？
没有啊，反正照起来看看，赶快出来。
We are unique. We are unique because we have a gym in the floor.
他们很不同，就是他们的运动场在病人房附近。
And just to take a quick peek, this is the other part of the gym.
这边另外一边你可以过去那边看。你们 PD
我们没有去看过复健科，也搞不清楚复健科到底。这边是我上课。这是什么？
We are big enough where they have their own departments. They have their area.
How many physical services in the world?
In this ward, physical therapists,
I think we only have 2 physical therapists, but then we have 2 physical therapy assistants and 2 rehab techs, so they can all help them.
we also have our own floor speech therapist.
当时有帮忙的，他有帮忙的。
Before they take you up, is there any questions you want to ask? Anything else?
And then it lists all of, this is a lot of information, but grooming, bathing, dressing up.
They have scheduled times. Because this is just one wing, 8 patients down one wing, 8 patients another, 8:24. We need to stay on a schedule because not everybody can come.
They go to nursing home, they go to somewhere else. In order to go home, you usually have to get.
Right, we have rehab technicians with our nursing aides. They come together. They bring them together. It's really a multidisciplinary team. Correct, and we put it on their wheelchair so that everybody can see it. That little plastic thing is their schedule.
他就是放在轮椅上面，这个病人也知道，其他人看到也知道。